Thank you very much. No disclosures for me. I thought I guess the limitations of conventional culture methods has meant that over the last 15 or 20 years we've seen a lot of effort put into the development of fungal biomarkers to act as surrogate markers for invasive fungal disease. So these may take the form of PCR-based assays to detect fungal DNA, or antigen-based assays such as those that detect beta-D-glucan or Aspergillus galactomannan. And over the last 5 to 10 years, we've really seen these actually become useful adjuncts for early diagnosis of invasive fungal disease. And we've seen them incorporated into care pathways and diagnostic algorithms. We've seen them be used to steward and monitor antifungal therapies, to predict treatment outcomes, and most recently in 2020, we've actually seen some of these biomarkers incorporated into the EORTC MSG ERC consensus definitions. So if we just look at PCR-based assays, which is all I'll be talking about today, you can use them in two different ways. And depending on which way you want to use them, it helps you determine what type of specimen you might actually be using and how often you may test. So if you're using it to rule out a particular disease, you want to use it as a screening test in asymptomatic patients and really utilise the high negative predictive value of these assays. In this way, we want to use it to preemptively diagnose infection in high-risk patients. And in that, you really need to have an incidence of about 8 to 10%. It doesn't make sense, it's not cost-effective to do a screening approach in patients with a lower incidence of disease. So because we want to screen patients, the best sample we want, well, the most sensible sample to use is to use a blood sample, because we can draw on blood quite regularly. And ideally, you want these types of tests to have a turnaround time of only about 24 to 48 hours. So you want the clinicians to withhold treatment till you actually get the results back. So short enough to actually impact therapy or impact patient management. Alternatively, we can use them to support a diagnosis, and in this way we may use it to upgrade a patient's classification as possible to probable IFD. So it enables a definite diagnosis in patients with clinical signs and symptoms. So they already have these symptoms and they already have a higher pre-test probability. So if we just look at Aspergillus PCR to start with, this Aspergillus PCR was incorporated into the latest iteration of the EORTC MSG criteria as providing mycological evidence of disease, whether we use a blood sample or a BAL sample, and there's a number of, you need at least 2 positive blood samples or 2 duplicate positive PCRs from a bowel fluid, or you can have 1 of each. Systematic reviews and meta-analyses have shown that Aspergillus PCR does provide a robust diagnostic test for screening patients who are at moderate to high risk of disease, or to confirm a diagnosis in those who already who may have an infection. There are a number of technical considerations that need to come into play when it comes to performing your DNA extraction and PCR, and it's actually your DNA extraction that's the critical step. There's lots of papers out there which describe these, which basically you need to use a decent amount of specimen. So your specimen volume from blood, if it's whole blood, is at least 3 mils. From serum or plasma, only about 0.5 mil, but still that's a lot more than a lot of these commercial kits suggest. You must use mechanical disruption of the cell wall to allow you to actually obtain a good DNA extraction, and you want to elute in less than 100 microlitres. So the PCR itself is not particularly rate limiting, but there are a number of recommendations, and these include things like using a multi-copy target to increase your sensitivity. Ideally, actually using a pan-Aspergillus target, because whilst Aspergillus fumigatus probably accounts for about 85% of our infections, there's 15% of infections that are caused by other species. And so if we only had a fumigatus target, we'd be missing a significant proportion. And qPCR is recommended to minimise our risk of contamination. So over the last probably 5 to 10 years, we've seen quite a few commercial assays being developed for Aspergillus, and these provide standardised methodologies and they perform independent QC of reagents. That's been one of the limitations before, is that we've got a lot of Aspergillus in the environment, so our reagents can become contaminated. They don't have as good sensitivities in serum compared with respiratory specimens, and there's relatively little data on their performance in proper clinical studies. Some of these assays do detect the most prevalent CYP51 gene mutations that confer azole resistance, but not all of the CYP51 mutations. So we know that if we get a negative result from a negative Aspergillus PCR result from an antifungal drug naive patient, we should have confidence that they don't have invasive aspergillosis. And similarly, if we get a positive PCR, it is a useful tool, a useful result to aid diagnosis. But you have to remember that from a BAL specimen, it doesn't discriminate between colonisation and invasive disease, which is why it's only associated with a positive predictive value of about 72%. So as I mentioned before, there are a few commercial assays that that look at detecting azole resistance by PCR. They haven't had a whole lot of validation in the literature. One study recently looked at the performance of the 3 assays that exist and to see how they performed when testing BAL specimens. The Mycogene had the best sensitivity, but this assay only has a Fumigatus-specific target. The Fungiplex and the Aspergillus have a genus-specific target, and then the Aspergillus also has a species target for Fumigatus and a species target for Tereus. So these 2 assays actually, whilst they had lower sensitivities, certainly the Aspergillus had a better positive predictive value, and all of them had pretty similar negative predictive values. Now, unfortunately, only one of these samples was found to be azole resistant, and it was a TR34 mutation. And actually, at this stage, these assays don't necessarily offer a better performance over just conventional culture. So moving on now to Mucorales PCR, we've heard already that the incidence of these infections is increasing, and that's due to a number of factors, including our patient cohort, our number of susceptible patients is increasing. We've seen changes in antifungal practice, and we've also actually got improved diagnostics, and that's led to a better, that we're actually recognising it better. We know early diagnosis is key to improving patient survival. So, not surprisingly, using PCR to diagnose or detect Mucorales in fresh tissue has increased sensitivity over paraffin-embedded samples, but we still can get good results from at least kind of 50 to 90% of formalin-fixed tissues. PCR has been used to aid diagnosis in pulmonary cases of mucormycosis. One study found that PCR was positive in all 10 patients who were classified as having proven or probable disease, and actually PCR was the earliest indicator of disease in 4 of those patients. Now, interestingly, 6 of the patients actually had co-infections, so they were co-infected with both Aspergillus and Mucorales. So these encouraging results support perhaps the inclusion of Mucorales PCR in the diagnostic algorithms, but unfortunately standardisation's been where it's probably fallen down to date. So this recent study published by the French group, the MODI-Mucor, was a prospective study that looked at the performance of screening, as an in-house PCR to screen high-risk patients to determine whether that was useful for early diagnosis of mucormycosis. So they enrolled 232 patients who were deemed at high risk of a Mucorales infection, and they were screened, their serum was screened twice weekly. The in-house assay they used had 3 targets, so Lichthemia, Rhizomucor, and then a combined Mucor Rhizopus target. The sensitivity of the assay was about 85%, specificity close to 90%, and positive likelihood ratio of 8.3, negative likelihood ratio of 0.17. PCR was the earliest sign of disease by about 4 days, and was positive at least one day before the first imaging was actually performed. And interestingly, a negative PCR result within 7 days of receipt of liposomal amphotericin B was actually associated with an 85% lower 30-day mortality. So this would argue for the inclusion of Mucorales PCR in the next iteration of EORTC MSG definitions. As I said, probably the limitation so far has been the lack of commercialisation of Mucorales PCRs. There are at least 3 assays that I saw in the literature that were recently reviewed in the Journal of Fungi, and they've got slightly different targets. Now, unfortunately, there's not really a whole lot in the literature of how these have actually performed in real life. The exception to that is the mucogenius, which has studies have found that it is useful for the detection of Mucorales DNA in a variety of clinical specimens. The assay is quite quick to perform, only about 3 hours for results. It's shown good performance when tested, when bowel specimens were tested, with sensitivities of about 90%, specificities of close to 98%. Missed one case of low fungal burden. Similarly, performance in blood, sensitivity of about 75%, which is not bad. And one recent review did report that it actually had lower analytical sensitivities to an in-house assay and decreased detection of the Lichthemia organism. So, as I said, it's just not had a whole lot of validation in real life. So pan-fungal PCR, you can't have a PCR for every single fungus that we're likely to come across. So pan-fungal PCR offers the opportunity to be able to detect any fungus when you're not necessarily thinking that it might be a fungus, or you haven't been able to prove that it's an aspergillus. So these assays usually target the fungal barcoding regions, so ITS, 28S, part of the ribosomal DNA, because they're multi-copies, so increased sensitivity. And then you would blast your sequence or PCR product against well-characterised or well-quality controlled databases. The best results with this type of approach are from sterile site specimens, not BAL fluid, and I'll touch on that later. Early studies found that it actually has the ability to detect novel or unexpected pathogens. So this study from 2013 found that 44% of the samples were actually positive for non-aspergillus and non-candida. So they're positive for things like Fusarium, Scedosporium. So in 2020, the EORCT did incorporate pan-fungal PCR and recommend the use of PCR and DNA sequencing in detecting and identifying fungi from formalin-fixed and fresh paraffin, or formalin-fixed and fresh tissue samples, but they do make a couple of really important recommendations. You really should only perform it when histopathology is actually positive or microscopy is positive. It's not recommended if it's not the case. Identification must be consistent with the histopathological features. You must have rigorous quality control. So negative controls, positive controls, but also controls to check that there's actually DNA there to begin with. The best targets are the ITS or 28S genes. Every product must be sequenced, and it's really only recommended for performance in reference centres. So unfortunately, this does mean that samples do need to be sent to your referral centre, which does delay results. But it does fulfil the criteria of proven fungal disease. So if we look at its performance on tissue, the diagnostic yield increases with your pre-test probability, and performance, so in patients who were deemed to have probable or proven disease, PCR was likely to be positive in about 71% of patients, whereas on samples where there were no fungal elements, less than 10% of tissue specimens tested positive in this study in 2017. It's important to also know that the type of specimen changes the performance of these assays. So core needle aspirates and fine needle aspirates are much less likely to give you a positive result than perhaps a proper open resection specimen. So we recently reviewed the performance of our pan-fungal PCR on histopathology specimens, because we were getting a lot of specimens where histopathologists reported that they didn't see fungi, but they wanted to check that there wasn't fungus there. So we reviewed the results from nearly 250 samples. 28% of those yielded invalid results. So by invalid results, I mean that there was no human DNA detected. So we didn't know whether the sample was inhibited because of all the formalin fixing and deparaffinization, or whether there was actually not enough DNA there to begin with. So that got rid of a quarter of our samples straight away. No result was given. Only 45 of those 250 specimens, or 248 specimens, actually were positive in histology. And of those, 49% yielded a positive result. But actually only 36% of them were clinically significant results. And by clinically significant, I mean they weren't things like penicillium or perhaps alternate, things that were just likely to be possibly environmental. So they didn't match the histopathology. And only 9% of those histology negative specimens yielded a positive result, and 3% of those were deemed to be clinically significant. So if we look at the cost of this, for a positive histopathology result, the cost in Australian dollars was about $250, but that was more than 10 times more for those which were histology negative to generate a clinically significant result. So from this, we've made recommendations, and we're trying to implement it, is that we don't do testing on histopathology negative samples, but this requires a lot more stewardship from our microbiologists. As I said, panfungal PCR on bowel fluid, it's the bane of my life. 50% of the samples, or most of the samples, are going to be positive with things like Candida, Saccharomyces and Rhodotorula. Importantly, the sensitivity of performing panfungal PCR on patients who are receiving mould-active treatment is actually significantly reduced. And so the diagnostic, we looked at the diagnostic utility of performing panfungal PCR on bowel and found that 53% of our samples were positive, but of those, only 8.5% of them were clinically significant. So the non-candidas, non-yeast. So from this, we recommended that really performance of panfungal PCR on bowel fluid should really be performed on high-risk patients who already have clinical and radiological evidence of IFD, so who've already got that increased pre-test probability. Just briefly, pneumocystis. It's the de-skilling of laboratory staff, and I guess the change in pneumocystis. In HIV, the load is much higher, whereas we see pneumocystis in our immunocompromised patients, and the load is much lower, so microscopy is not necessarily as sensitive. So we're increasingly seeing pneumocystis PCR being performed by many diagnostic laboratories. It does detect colonisation, asymptomatic infection, subclinical and active infection. So it's really important that a positive PCR result is correlated with radiological and other laboratory findings. The ECIL guidelines do recommend the use of real-time PCR for routine diagnosis of pneumocystis. Bowel specimens are the best specimen, but you do get positive results from other specimens when perhaps a BAL specimen is not possible. So pneumocystis qPCR was incorporated into the 2020 diagnostic criteria for pneumocystis as mycological evidence of pneumocystis disease, and they recommend that you can use BALs, induced sputums or oropharyngeal washes, but they don't recommend a threshold for positivity. Now, there are numerous commercial assays available, and these show excellent concordance with in-house assays. Now, the Fungal PCR Initiative Working Group are working to develop some consensus methods for DNA extraction from various bowel fractions to try and assist with standardisation and perhaps lead to the use of quantification. So, again, briefly, Candida PCR. Now, the idea of Candida PCR fulfills many of the criteria of what would make an ideal diagnostic test for invasive candidiasis. It's sensitive, it has the ability to be multiplex, offers rapid turnaround times, you can test blood, which is minimally invasive, it provides speciation, often it's positive before culture. But at this stage, utility is still not really clearly defined, and the use of Candida PCR does differ in different clinical contexts. At this stage, Candida PCR does lack standardisation, and there's limited validation in real-life prospective settings. So the Fungal PCR Initiative group are working towards developing a standardisation for performing PCR. Now, there are numerous commercial assays that are available from a variety of different companies. Most of them target the top 5 candidas, so albicans, glabrata, Parapsilosis tropicalis and krusei, and then some of them have specific targets for Candida auris, perhaps for screening patients. What you decide to use really depends on your laboratory, your budget, and your workflow. So I'm not making any recommendations, but just to say that there are actually quite a few commercial assays out there. And finally, just Cryptococcus PCR. So we see a decent amount of Cryptococcus in Australia, which is where I'm coming from, and we do get quite a bit of Candida glabrata. So Cryptococcus gattii. So there are commercial assays for Cryptococcus, the BioFire and Oz Diagnostics. They are 2 of them. But they're quite special. They specify which specimens you can actually test. So they're limited to usually CSF and respiratory samples. And in our pan-fungal PCR, we had quite a lot of tissue specimens where they were sent to histopathology because they thought it was a tumour, and on histopathology they then saw encapsulated yeast cells. So we had quite a lot of times where we were getting formalin-fixed tissue where people wanted to know whether it was neoformans or was it a gattii. And none of these commercial assays have the ability to discriminate between the 2. So we developed a real-time PCR to detect and identify Cryptococcus neoformans and gattii from sterile and non-sterile site specimens using high-resolution MELT analysis. So with the high-resolution MELT analysis, this assay has the ability to detect all the molecular types of Cryptococcus neoformans and gattii, and all the neoformans have a melting point of 81 degrees Celsius, and all of the gattii have a melting temperature of about 79 degrees Celsius. So we've been able to put this into routine use and give an actual species identifications on a lot of those formalin-fixed sections. So in conclusion, important advances in standardisation of PCR tests have occurred in the last 10 to 20 years, and we've seen these incorporated into the EORTC criteria. But PCR tests are not standalone tests. They're valuable add-on tools which fulfil the diagnostic gaps, but we must optimise the test algorithms. It's really important that all PCR results are interpreted in clinical context of the patient and other findings, particularly if your patient's receiving anti-mold therapy. A negative Aspergillus PCR may not actually be that meaningful. So it's really important that we perform risk factor stratification. So we want to predict the individuals at the greatest risk whose a positive PCR result actually carries the greatest weight. Thank you.